It is my great pleasure to host today in this Ask the Author session Professor Ayako Suzuki, an adjunct professor at Duke University who recently moved to Japan. She published a very important paper in The Lancet. The title of this publication is Age-Specific Protective Effects of Statins Against Cirrhosis in Patients with Chronic Liver Enzyme Elevations Associated with Metabolic Dysfunction, a retrospective cohort study of electronic health records. So statins are gaining a lot of attention in hepatology. We know that statins reduce the risk of hepatocellular carcinoma, but there are two important points here, is that I'm always discussing with GPs to give statins with patients with chronic elevated liver tests. They have some kind of resistance to do that. And I also would like to give statins before the patients have actually a cirrhosis or risk to develop hepatocellular carcinoma. So I think this paper addresses these 2 points. It is really great to have you with us today, Professor Suzuki. Thank you very much for accepting to do this interview. First, congratulations to you and your co-authors for these publications. Let me ask you the first questions. What is the design of your study?
Let me explain a little bit. So, as you said, this is a retrospective cohort study using electronic health record, EHR, from the U.S. Veteran Health Administration, which is one of the largest integrated EHR system in the country. So first, we identified individual with chronically elevated liver enzyme not explained by viral hepatitis or other non-chronic liver disease. And in most cases, these abnormalities were linked to underlying metabolic dysfunction. So this population is presumed to represent a MASLD. Then we followed this cohort for up to 10 years, tracking incident cirrhosis using relevant ICD code. To evaluate association between the statin exposure and the cirrhosis risk, we applied a Cox proportional hazard model with and without a time-dependent variable, incorporating statin exposure at the baseline and during the follow-up. Unique aspect of our approach was statin dose standardization, because statin potency varies widely across formulation. So we standardized dose using simvastatin equivalent scale based on LDL lowering intensity according to a published conversion table. I should note that this work was funded by U.S. Department of Defense through Translational Team Science Award, which has recently concluded.
And so with this design, very large number of patients, what are the main findings?
So as you said earlier, the association between the statin use and the protection from the cirrhosis is not new. And consistent with prior research, we found that the statins were associated with reduced risk of cirrhosis in this cohort as well. But one of the most notable findings was the age interaction. Older patients appear to experience greater protection from statin compared with the younger individuals. But we did not observe sex interaction in this cohort, although this may be influenced by predominantly male population in this cohort. We also saw a clear dose-response relationship. Higher cumulative exposure to statin was associated with progressively lower cirrhosis risk. So together, the age interaction and the dose-dependent effect aligned with LDL lowering intensity offer potential mechanistic insight, suggesting that the protective effect of statin may be related to modulation of cellular cholesterol metabolism and potentially intersect with aging pathway. Finally, no specific statin formulation demonstrated superior protective effect at the baseline.
This is great. So never too late to begin, right? Even
Yes.
better if you're a little bit older to begin. It is not important for this to be a woman or a man. Good. This is perfect. So how do you see that in our daily practice? Shall we give statin to patients at risk to develop cirrhosis? And which statin then?
So let me explain. So I think our findings provide valuable insight into the effective use of statins for cirrhosis prevention in a patient with MASLD. To observe meaningful benefit, I think a patient at least need 20 milligrams simvastatin equivalent daily, regardless of specific formulation. For the patient younger than 54 years old, however, a higher dose, roughly equivalent to 40 milligrams simvastatin may be necessary. These findings suggest that moderate to high intensity statin therapy is essential for cirrhosis prevention in this population. That having been said, this was an observational study, so I have to say further validation, especially in a more diverse and gender-balanced cohort, will be critical before making definitive treatment recommendation.
Yes, prudent, wise. But nevertheless, this is very important, I think, and I hope that we will get more information on the benefit of statins in patients with MASLD at risk to develop cirrhosis. Thank you very much for sharing your thought about this publication, and congratulations again for it. Thank you, Professor Suzuki.
Thank you.